Federation very pleased and proud to represent a united labor movement in support of AB 52. We are united in our support because we have shared one universal experience, and that is our members continue to pay more and get less for their health care. At the bargaining table, increased health care costs, you've heard the numbers about how it's outpaced regular inflation. Those increased costs have eaten away every single year at any kind of increase in benefits we can get at the bargaining table, whether it's in raises, cost of living adjustments, anything. We can't get at the bargaining table because of the tremendous increase in health care costs. In our private sector unions, we have some of, we think, the most sophisticated healthcare purchasers available. And they continue to tell us, I've been up here probably 5 years now on such a bill, they continue to tell us that healthcare costs are a black box. They have no idea what goes into them. They sit across the table from the insurers and their third-party administrators, and they cannot still explain the intricacies and why our premiums continue to rise at the pace that they do. As we enter a world across this country and in California where every single American, every single Californian will face an individual mandate, a requirement to have health insurance, we need this bill now more than ever. Otherwise, each and every one of us will be captive audience, victim to the insurance companies' desires, whims, and profits. I'd like to point out that all other attempts to try, this has been a long-standing issue. We've been here for at least 15 years to try and deal with the tremendous growth in healthcare costs. Every type of policy intervention reform that we've taken has come on the backs of workers and on the backs of consumers, whether it's managed care, co-payments, deductibles, skinnier networks, specialty plans, whatever has happened, it's been on the side of consumers. And clearly, it just hasn't worked. It's time for a paradigm shift, a different way to try and control health care costs in a reasonable fashion, and we think that AB 52 does just that. I'm going to take just a second to address the issue of large group and whether or not they should be covered under this bill. Quite frankly, we have some of the largest purchasers in the state and across the country in our union trust funds, and we still simply cannot have the bargaining power to control our health care costs. It's hard to imagine that an employer with 51, 100, 151 employees could have that type of bargaining power. And frankly, we would be concerned if large groups are taken out of this bill. If everybody else has regulated and reviewed health care costs, there's going to be a push towards large group for people to make their margins there, and we would have real problems with that. Finally, I would close by saying I have spent much of my day today responding to calls from our members and leaders to understand the governor's legislative actions late last night. And quite frankly, I have no answer as to their questions of why. When they ask us, when the legislature had an opportunity to do something about the outpacing health care costs, if this committee does not pass this bill on, if this legislature does not send this bill to the governor, our members will continue to ask us why. And again, I will not have an answer for them. Please, we ask you to support this bill as not the panacea, not the end-all, be-all to do something about our outrageous health care costs, but as a solid step that shifts that paradigm away from the backs of workers and consumers and does something to affect the marketplace. Thank you.
Mr. Chairman and members, Barry Broad on behalf of the Teamsters, United Food and Commercial Workers, Unite Here, machinists, longshoremen, etc. For the second time in a decade in Southern California, we may be headed for a disastrous, costly grocery strike in which neither the union nor the employer really wants it to happen, and it's about health care costs. This is obviously an issue of great significance. I think the question we have to ask ourselves, we have to take a step back and look a little bit at the economics of this. When is rate regulation appropriate? When does it happen? And it happens when there are imperfect monopoly markets or monopsony markets. That's when it happens. Now, what is the world we are about to enter into? Everybody has to buy health insurance, so demand is inelastic. You have to buy the product or something the government gets mad at you. You have to buy the product. Therefore, you can't control the rate by leaving the market. So everybody has to buy it. There are, in the various regions of the state, there are sometimes 1, 2, maybe 3 viable competitors selling the product, which means you can't really go very much from insurer to insurer and get much of a difference. And our health plans sit down with people. And as much as we love Kaiser, for example, Kaiser sits down with union health plans and says, you're stuck with us, you're stuck with us, and there's nothing to negotiate. That's the relationship. And that's with us, because they know that we have a lot of our members there and we have to be there. They have market power. That's the third thing. There's a party that has market power. Market power means that they have power to contort the market and control the market. At the same time, you have heard all about these costs going up for health insurance. They've been driving down the costs for providers, who we also represent. Teamsters represent podiatrists. These insurance companies are lowering their reimbursement rates. At the same time, they're raising the rates to consumers. That's because they have market power. And that's an appropriate time for us to move into this model, which is essentially the utility model. That is to say, insurers have to provide the service to anybody, any willing buyer, and every buyer has to buy the service. And so it's an appropriate time to move to this. As to the concept, Senator Strickland, you were asking about just reasonable rates and so forth. We've been dealing with the concept of just, reasonable, adequate rates in utility regulations since the railroads were first regulated in rate regulation in the 19th century. It's in our Constitution. These are well understood concepts in which the last legal question about what they mean was resolved in the 1940s. It isn't really hard to figure it out. But what is the social contract we're striking here? It's the old utility contract, which is that these insurers are going to be guaranteed an adequate rate of return. And what that does is it smooths out the market. It doesn't mean that healthcare costs are never going to go up, but they're not going to go up. They're not going to spike and then go suddenly down, because people need predictability in a market. They need the rates to be fair, and in return, the market players here, the insurance companies, need to be able to recover their fair and adequate costs. And that means we may be buying them Mercedes, but we're not going to buy them Rolls Royces. But their shareholders are going to be just like the famous little old ladies who invested in PG&E and Southern California Edison and made their fair rate of return year after year after year, decade after decade after decade. And it's that predictability and fairness that will be put into the system, and it will save all of you, frankly, from when there's a 30% rate increase, for people to come running to the first politician that they can find and say, do something about it. And so I think we've got to go here. So we urge an aye vote. Thank you.
I think Senator Strickland had a question or a comment.
If I could follow up, Mr. Broad, do you know, you brought up the utility comparison. Do you know what the net profit margin is for the utility industry?
I don't know how they do that. And the important thing is that I do know this because I've participated in that for years.
Right.
They look at what costs they have to provide, and they make sure they have, and obviously it's different. There has to be adequate capacity. That's the question that Senator Rubio raised. Is there adequate capacity built into the rates? Can we reimburse people enough?
Just so you're aware, the utility net profit margin is about 8.5%, and we're talking about healthcare plans is about 4.3%. So they're almost double without regulation.
Well, I'm not sure that we're, I don't know if we're talking apples to apples.
I only bring this up because you brought up, I think you're talking apples to oranges as well, but you brought up the utility side.
Right.
But that's why I'm following up.
Well, I don't know that, I'm sure how they regulate the rates for utilities also depends on what, we're talking about gas or electric or trucks or this or that.
We're talking, I'm just following up, but we're talking about the profit margins.
It should be appropriate, and there should,
point well made.
work.
Let's move on to the next speaker, please. Thank you.
Thank you, Mr. Chair. Senator Seth Bramble on behalf of the California Teachers Association. Proud to be a part of the labor panel, but also a part of the quality public education panel, I would call it. Teachers throughout the state come to us and say, we need to do something about healthcare rate increases. Why? because what's driving negotiations at tables all across the state are really two factors. One is the money coming in per child more than what it was last year, less than what it was last year, the same as what it was last year, and what's going on with the health care rates. Those are really the two factors. These kinds of conversations that happen at the bargaining table are also what result in decisions like, are we going to eliminate a stipend for the yearbook advisor? Are we going to have adult education in this district next year? The worst kind of cut I can think of, are we going to have to take furlough days and physically shorten the school year for the kids? This year alone, not only do we have thousands of educators laid off, class sizes rising up. I mean, decisions at the bargaining table were what made the decision, for example, in high school English, whether you're going to have 35 kids in your classroom or 39, 40, 41 kids in your classroom. Certainly, healthcare rate increases across this state threaten the ability of districts to meet their fundamental educational missions. We've seen school years shortened throughout the state. We've seen student programs eliminated throughout the state. This problem is of greatest concern in small districts who maybe not only do the district but the association, neither one of them have the expertise or contacts to negotiate effectively with insurers and get those best rates. So this bill really will institutionalize much needed oversight, provide accountability to healthcare consumers. We're in strong support and urge your aye vote.
Thank you. Next.
Good afternoon, Mr. Chairman and members. I'm Dolores Duran Flores with the California School Employees Association. We're also here in support of this bill. I think health care issues are a huge issue in school districts. I think it's indicative of the fact that you have teachers here, support staff, as well as the California School Boards Association. Management and labor don't always agree on issues, but it's clear we agree on this one. We are suffering from the huge increases that we are experiencing on health care, and the CTA representative was right. It's like the number one issue besides furloughs, because we've taken massive layoffs, 22,000 from my members alone, 180,000 are furloughed. Beside those issues, increasing health care costs is the number one issue. My members who have been laid off have lost their health care. They're gone. Those who are being furloughed are trying to keep it. I just shot an email real quick to one of our field staff in Stockton and asked her, can you give me an example of a real high increase that our members are suffering through? They said just last year, Lodi Unified School District alone was 64%. And I'll explain to you a little bit about my members' experience. My members, when they negotiate health care at the local level, the school districts usually negotiate a cap. So they'll say, for instance, we'll pay the first $200 for individual coverage. We'll pay the first $400 for family coverage. Well, obviously, my members are paying hundreds of dollars more a month because they're paying the difference for individual care. And also for family care, they can pay upwards to $1,000 or more. And these are people who, on average, my full-time members make about $25,000 a year. My part-time members make, on average, $12,000 a year. So you have a situation where many of my members are just working for the health care. At the end of the month, they endorse their checks back to the school district. And every time the rates increase, they pick out their personal checkbook and they write the district a check for the difference. This is unsustainable for us. One more example I promised one of my members I would share with you today because it's very important to her, and she's not alone. She wanted to let you know that she's a single mother. She has two sons, two actual teenager sons, and her health care rates have increased significantly. She was in a situation where she had to choose which son to cover, because she couldn't cover them both and still provide health care. Still provide housing and food for them. She chose the wrong son. 2 weeks after she chose not to cover him, he was in an automobile accident. So now she is paying extremely high health care costs now, and she's facing bankruptcy. She's not alone. We need this bill. Thank you.
Mr. Chair, members, Deanna Furman on behalf of the California Nurses Association. We represent about 86,000 nurses in California. Our experience at the bargaining table is similar to what everyone else has said. Healthcare is a constant issue. Our recent one-day strike at Children's Hospital Oakland, the sticking point is about healthcare, specifically dependent healthcare. Here's a great hospital providing specialty care and yet struggling to provide affordable healthcare to its members, and that contract remains open right now. Additionally, as nurses, we're patient advocates, and that's one of the biggest reasons why CNA supports this bill, is because during this ongoing economic crisis, as people are losing their health insurance or they're getting reduced insurance and they're delaying care, when they finally wind up to see a doctor or nurse, their condition is often a lot more severe than it would need to be. If rate regulation was implemented, it could hold down rates and people could go and see their doctor and get the care that they needed sooner. And lastly, I'll touch on the point that other people have mentioned. You know, CNA, we were against the individual mandate because we thought that that would be unfair because we had serious concerns about the rates. And so a lot of you and your staff told me that your top priority was making sure that federal health reform was a success and implementing it was a success. And I just have to remind you that in this era of the health exchange and an individual mandate where people are going to be required to have insurance, to protect consumers, it's so important that there's rate regulation that accompanies that. Thank you.
Good afternoon, or is it evening? Dr. Chairman and the members of the committee. I'm Sarah Nichols on behalf of SEIU, the largest union in the state, and SEIU California, the state council. And this was not an easy decision for us to come in support of this bill. It's been a long time coming. We have, as a union that also represents the most healthcare workers in the state, we really had to look carefully at the effect on health costs, at the effect on healthcare workers. And we have come to the conclusion that rate regulation is absolutely necessary in order to successfully implement the Affordable Care Act, which is our top legislative priority in this state. We don't believe that we can go out, as we plan to, send thousands of workers out to credibly argue to people that they need to fulfill that individual mandate and come forward and buy these health care products under the exchange if the prices and premiums that are being offered are not fair and defensible and affordable. So we trust the regulators to take into account the need for healthcare workers and all healthcare providers to be reimbursed at the rates that they should be reimbursed. We trust them to do that. We know that that's going to be taken into account when those premiums are set. We see that that's what's taken into account in the states that do it right. And that's why we're here today asking for your aye vote, asking you to pass this important legislation. Thank you.
Next.
Mr. Chairman and members, Brian Rivas on behalf of the California School Boards Association. I'll be quick. Just wanted to make 4 major points, really. Like all Californians, school employers have seen a steady increase in the cost of health insurance. Between 1998 and 2008, the amount that school employers spent on health insurance actually doubled to over $5.5 billion. And the best information we have available from the federal government indicates that the total amount we're going to need to spend is going to continue to rise to over $10 billion by the year 2019. So in light of those increases, and I don't think anybody expects any kind of corresponding increase in the level of support from the state for public education, our ability to recruit and retain good people and deliver the instructional program for our students is going to be strained because the amount that we have to devote to healthcare is going to take up an increasingly large portion of school district budgets. So in light of those facts, we don't think it's too much to ask that someone like Commissioner Jones be authorized to reject premiums unless they can be explained and justified. So for those reasons, we're in support of the bill.
Thank you. I believe we have one last group, or anyone else like to speak? This is anyone who'd like to speak in support. In light of time, we appreciate if we can just make comments just very brief and short.
Mr. Chairman, members, David Jones on behalf of the City of Sacramento. I'm happy to support our hometown guy here. This is great policy and would encourage your aye vote. Thank you.
Thank you. Next.
Henny Kelly, I'm here on behalf of the California Alliance for Retired Americans. We have 900,000 members. Many of our members are in that age group between 50 and 65. And we need this. All of our members need this. And we would ask you for your support.
Randy Hicks of Californians with Disability Rights and Healthcare for All of California. For the disability community, what's happened with them was before they apply for disability, they are caught in between having no insurance. And then when they try to get insurance on the open market, they have a pre-existing condition. We realized the American Affordable Care Act would take care of some of these issues, but they're still going to have that increased insurance cost. So we support AB 52, and we thank the author.
Vic Guzman for the California Alliance for Retired Americans, and we're in support, but also I am representing the bakers, confectioners, tobacco workers, and millwright workers, retirees, and we are in support.
Mr. Chairman, committee members, my name is Stuart Ferry on behalf of the California chapters of the National Multiple Sclerosis Society and also the California Neuro Alliance, a coalition of people living with neurological diseases. I'd just like to say that, there's not a person sitting in this room today that either themselves has a chronic health condition or knows someone dear to them who does. And so, therefore, by necessity and through no fault of their own, they're frequent users of the healthcare system. And as a result, exorbitant rate increases, if that's, continues to be the case, that will affect a person's ability to get quality health insurance. That, in turn, affects their ability to have appropriate ongoing care that they need to be an integrated member of the community and on the job and producing to the tax base. And all of us want those things. So I urge your support, and thank you.
Thank you. Next.
Mr. Chair, members, Christy Bama representing the California Professional Firefighters. I share the remarks made by the labor panel, and additionally, as public safety personnel, we are the health care provider for those who have no access to the health market, and urge your support.
Thank you.
Good afternoon, Anna Quiros on behalf of the Latino Coalition for a Healthy California, just in support of the bill.
Thank you.
Mr. Chair and members, Brianna Pittman with Planned Parenthood Affiliates of California, also in strong support of the bill.
Hello, Amy Petray-Hill with the Unitarian Universalist Legislative Ministry of California. Here for two reasons. One, this is just the right and fair thing to do. Number two, our own congregants, because we represent members of churches across California. For them, this has been their top issue because we represent them. They've told us in their congregations, healthcare is one of their top issues. They're successful doctors, they are business owners, they are employees, and they're saying, we're getting squished. We can't, even if we want to purchase the insurance, we can't do it because the rates are too high. And so we're not allowed to do what our conscience tells us to do, which is to purchase insurance for our employees. So there's both moral and economic components to this bill. We very strongly support AB 52. Thank you.
Thank you. Next.
Pam Bichila on behalf of the Alameda County Office of Education and Alameda County Superintendent of Schools Sheila Jordan. We strongly support this measure to help families get the resources they need to send their students to school healthy and ready to learn.
Thank you.
Jeanette Sarifati, Legislative Staff Attorney on behalf of the Mexican American Legal Defense and Educational Fund. I'm here testifying on behalf of AB 52 for the Latino Health Alliance, which is a statewide coalition of organizations dedicated to promoting the health of Latinos here in California. Part of our coalition includes, in addition to MALDEF, the California Immigrant Policy Center, the National Council de la Raza, Latino Coalition for a Healthy California, and California Latinas for Reproductive Justice. Thank you.
Thank you. I think, yes, there was a question, Senator Strickland.
Thank you, Mr. Chair. As we're done with the proponents, I just wanted to address either the commissioner or the assemblyman. We've heard a lot of testimony from your supporters and the proponents that the rates will go down if this measure is enacted. How much will the rates go down?
I think it's impossible to predict exactly what will happen to an individual rate. We can look to other states' experience, though. And as was testified to, in New York and Colorado, I think in Oregon too, about half the rates that were proposed were accepted. About half of them were modified because they were deemed to be excessive. Our experience here might mirror that. It's hard to know. We also know that in the past number of months, The Commissioner has been confronted with an array of increases, many of which have unilaterally been withdrawn once it's been revealed that either they're not actuarially sound or because of other reasons. So it's very hard to know for sure.
So for example, you say New York, how much did their rates go down?
I can, you know what, Senator, let me get back to you if I recall correct. The amount I think is in the teens for rates that were rejected as being excessive, but I will get you tomorrow specific information about the percentage by which rates declined there.
Thank you.
I can do that in other states as well.
Thank you.
Okay, we're going to now have the opposition side. We're going to have the providers, insurers, and everyone else. I would like to give them the same amount of time. It's all fairness to at least have questions answered, have their position stated. So the first group will be the providers.
Good afternoon. Lisa Fulber with the California Medical Association. I'm Vice President for Medical and Regulatory Policy at CMA. And I know it's probably a little strange to see CMA sitting side by side with the insurers because we have been very strong proponents of reining in insurer costs, including our multi-year effort to implement a medical loss ratio here in the state. But we are here in opposition today because we do believe that this bill will have unintended consequences. As dysfunctional as our healthcare system is, it is still a system, and you cannot touch one part of that system without impacting other parts of the system. Physicians in California are getting squeezed. Under the Brown administration proposal, physicians will receive just $11 from the state for a basic Medi-Cal office visit. And those physicians who are still willing to see Medi-Cal patients, they're at a tipping point where they have a very fragile balance between their commercial payers and their Medi-Cal payers. And if commercial rates get squeezed, it will mean that they will not be able to take Medi-Cal patients anymore, or will have to seriously reduce the number of patients that they take. This bill is intended to protect primarily those in the individual and small group markets. We do believe that federal reform helps to address this very issue through things like the exchange. The exchange will also cover the folks in the individual market and small businesses. There are expected to be between 4 and 4.5 million Californians that will go into the exchange. And under federal reform, the exchange can selectively contract and can reject an insurer whose premiums they decide are too high. We also believe that this bill does nothing to address the real cause of increase in health insurance premiums. And there are a number of things that are happening through federal reform that attempt to do just that, including some delivery system reforms, including ACOs and medical homes, the medical loss ratio, first dollar coverage on preventative services, and the widespread adoption of electronic health records and health information exchanges. We believe that these will be more effective in addressing those root causes of increases and actually look to reduce those healthcare costs instead of arbitrarily applying a potential rate reduction. Consumers and employers are understandably concerned about rising healthcare costs, and physicians, more than any other group, can tell you what the impact of lack of access will mean for patients. We continue to be committed to looking for real solutions to address that. We don't believe that this bill does that. Thank you.
Mr. Chairman and Senators, Martin Gallegos with the California Hospital Association. We also are opposed, while we share the concerns of many of the folks who've discussed this issue, because many of our hospitals are employers. We are also, of course, concerned with the rising costs of health care and health insurance premiums. But we think that AB 52 doesn't really get to the root cause of these rising medical costs, and I'll explain why. There are a lot of factors that are involved with rising health care costs, namely the aging of the population, the obesity epidemic, the growing occurrence of chronic illnesses among the older population. This requires more care from those groups, so you have more folks using the system. The other, and there's been some talk about this entity called a cost shift, also commonly referred to in other parlance as the hidden tax. Studies have shown that this cost shift can actually add 20 to 30% to the premiums that payers are paying for health care coverage. And this cost shift is generated because of the uninsured and uncompensated care that providers are delivering, as well as the underpayment for Medi-Cal and Medicare. In hospitals alone, just last year in California, that uncompensated care totaled $12 billion and represented about 20% of the gross revenue that was generated from hospital services in the state of California. So that's a big chunk. And no system can continue to sustain that economically. So what happens is when providers go, and particularly hospitals, go to negotiate rates with commercial insurance plans, they factor that into what they're negotiating for their reimbursement rate. If all of a sudden these premiums are capped or don't provide health plans with the adequate ability to deal with the cost shift, then that means hospitals and other providers are not going to get reimbursed adequately. And what's going to happen is you'll have folks that'll just stop taking those government programs. And I wanted to mention one thing about some remarks that were made earlier about the cost shift and adequate reimbursement. Let me be very clear. When folks look at cost data that's reported by providers, including hospitals, that cost data, that doesn't reflect the impact of the uncompensated care and the cost shift. What you look at when you look at cost data, you're looking at what it actually costs the provider to deliver that service, whatever it is, hip replacement, coronary artery bypass, whatever it is. That's what you're seeing. The cost shift comes into play when providers negotiate the rates with the health plans. So if someone looks and says, well, let's make sure providers are getting adequately reimbursed, and you look at cost data, let's say on the OSHPD website, yeah, you'll see what it actually costs to provide the service. But you can't see what is, in addition to that, the cost of providing charity care, uncompensated care, care to the uninsured. That happens, as I mentioned, when the rates are negotiated as part of a contract agreement between the two parties. So that's why we're very concerned that if this bill goes through and the rates for health plans are not adequately provided for, it's going to have a trickle-down effect to providers, and what that is going to do is impact access to care. Hospitals will just have to either cut back on services, they'll have to shut down units, they'll have to close wings, they'll have to lay off individuals because they can't continue to sustain a 20% impact of uncompensated care and continue to provide the same level of services that they currently are. So for these reasons, we're opposed, and we ask that you vote no on the bill. Thank you.
Thank you, Mr. Chairman. Bill Barcelona, California Association of Physician Groups, otherwise known as CAPG, representing 150 medical groups and IPAs across the state, serving 15 million Californians. My testimony is very similar to the two colleagues who went before me, and so I'm going to shift gears just a bit. I have 3 points that I want to make for you today about AB 52. I want to focus in on its ability to be administered in an effective way, and I want to talk about how it has a potential to undermine the exchange and CalPERS in their selective purchaser models. And finally, I want to close with the impairment to patient access to their providers as the squeeze of the commercial premium occurs under this kind of a model. So let me begin with the administration issue. And Senator Rubio, you asked questions earlier about where the Department of Managed Healthcare was at. I don't speak for the DMHC, but I used to work there. I used to be the Deputy Director for Planned Provider Relations about 5 years ago. And along the way, I manage the licensing division. And so I've done some calculations kind of on a back-of-the-envelope basis about what the increased filings would be under this new bill that concern me. So the health plans have stated that they believe that AB 52 will generate 16,000 new filings a year. And that is over and above the filings that we're seeing with the implementation of 1163 from last year. And I believe that is because what we're doing now with AB 52, if passed, is adding the large group market to the review process. And each and every one of those customized large group employer contracts must now be submitted for review. So that adds thousands and thousands to the volume that has to be under review by DMHC and by CDI. So just back of the envelope, since I used to manage the licensing division, there's 17 employees in the DMHC licensing division. They review collectively about 2,100 Knox-Keene required filings a year. Now, that's not rate review filings. That's just all the kind of filings that are required under the Knox-Keene Act. So that yields a productivity of, I don't know, about 123 filings reviewed per reviewer per year. So if you take that as an existing rate of productivity by the DMHC, if you add 16,000 filings to that, what you're going to see is a need to increase the licensing review staff by 130 new state employees. That's just simple back-of-the-envelope math. I don't know that we get to $30 million with that, but at about $100,000 for a PY and 130 new employees, and that's just the reviewers. You've got to add office space. You've got to add technology. All these people need computers because all the filings are electronic. You need support staff. I think this is a big undertaking. And by the way, there's only 270 people at the Department of Managed Healthcare right now. So adding 100 or more is a pretty significant addition. So I'm worried about this creating a bottleneck for the large group market. Let's talk about the exchange and CalPERS now. So AB 52 is designed to decrease premium rate increases, and yet that's what CalPERS does. CalPERS delivered an across-the-board premium cost this year of just 4.1%. Now, medical cost inflation was right at about 3% nationally. So CalPERS delivered a pretty successful level of increase relative to the overall market. That's pretty good considering they only have leverage for about 1.3 million enrollees. The exchange, on the other hand, will have 7 million by the time it is fully up and running. So it would have 3 to 4 times the numerical leverage to negotiate contracts. But that's only if it's allowed to pursue the selective purchaser model that CalPERS now uses. If there is prior rate review, then there is a double bureaucracy that's added to that process, and we've already just discussed how many people it will take and how much time that would take. So I'm concerned about that. Finally, I share the comments of my colleagues about how this blunt rate review mechanism of premium rate control can affect the cost shift that occurs now that providers must bear in this state because of the increasing underpayment for Medi-Cal by the state of California. My groups, the provider groups in California that serve half the insured population of 15 million people, are paid on a capitated basis. And so when you hear the proponents of this bill say that no other state has suffered a decrease in payments to providers, you have to remember that California is unique among the 50 states. We predominantly pay capitation to over half of, for the providers who serve half of our population. Capitated contracts are typically, not always, but typically written on a percentage of premium basis. And so when you apply blunt rate control mechanisms like premium rate review, we don't know what will happen to providers' capitated contracts. There has been no economic analysis of that by a healthcare economist to determine what the impacts will be, and that's why we're concerned about the uncertainty of this legislation at this time. Thank you very much.
I believe the senator had a question.
For the gentleman just testified. Does rate regulation control utilization? You have, Mr. Barcelona, you have a lot of experience in healthcare, many different avenues.
Does it impact utilization of services?
Does it control it?
No.
Okay. Does it control the cost of technology?
It can.
Medical rate of inflation?
It can.
General inflation?
I don't know.
So my question is, how do we reduce premiums if a lot of those answers you just answered no?
Well, how we've done it in California for the last decade is to use this delegated model that I represent. We've delivered costs far below the national average for the previous decade in terms of medical cost inflation. So it is a very efficient model. In fact, Massachusetts just released a study this week. They have a cost control containment commission. They just released a study this week, and they are looking at emulating our model of capitated payments as a primary cost control mechanism. Now, we're 10, 20 years ahead of them.
If I could shift gears a little bit, there's a lot of unknowns when we talk about healthcare, what's going on in the federal government in terms of the exchange and moving forward on what could potentially be the Obama healthcare plan. How would this piece of legislation affect? I believe it was Senator Alquist that did the exchange here in California. How do they match each other up?
The exchange would, like CalPERS, negotiate rates with their qualified health plans. Once those rates are negotiated, they would have to be submitted by the carriers to the DMHC or the CDI, depending on who regulated that particular carrier and what product they offered. Any product change for a copay, a deductible, or a premium rate would have to be submitted for review under AB 52. So when you're talking about including the large group market in this process and these thousands and thousands of additional filings, you have to remember that it's going to require someone at a regulator's office to review each and every one of these changes and sign off on them. Now, you have about 250 working days a year. And the problem here is that in the large group market, it's concentrated. It's not distributed over those 250 days. It comes in waves in the spring and in the fall for large group open enrollment. So you have to meet time deadlines for CalPERS, for the exchange, and for large group employers who offer a variety of plans. And so I'm concerned that the regulators won't be able to meet those deadlines, and it's going to hinder open enrollment processes in all three of those areas.
Right, thank you.
Okay, next.
Thank you, Mr. Chairman and members. Teresa Stark on behalf of Kaiser Permanente today. I want to echo the comments of my colleagues from the provider community, but just add a couple comments from the unique perspective of Kaiser Permanente. We have an integrated healthcare delivery system that provides care to 6.8 million members in California. We do that through a system of 34 hospitals, 333 medical office buildings, nearly 300 pharmacies, over 12,000 physicians, and over 125,000 other providers and staff. The revenues that we receive from our member dollars essentially go to four purposes: to provide care to our patients, to operate our integrated delivery system, and to support our community benefit activities, our investments in and our support of our local communities. After we have met those obligations, the remaining funds are reinvested back into our system, back into our patients, building hospitals and other facilities, and investing in technology and equipment to benefit our patients. We are building or expanding or upgrading several hospitals in the state over the next 4 years, and in doing so, we've created hundreds of jobs in those communities. Our core mission is to provide superior health care to every single one of those 6.8 million members, while being responsible stewards of our member dollars. We've been doing this for over 60 years, and we intend to continue. That's what drives us. However, we firmly believe that this bill we are discussing today will interfere with and jeopardize that mission and our ability to continue to deliver care in this way. And honestly, I think we have to ask the question, is this what we want to be doing with our scarce healthcare dollars? Forgive me for invoking some Ross Perot here, but that loud sucking sound that you hear is this bill siphoning tens of millions of dollars out of the healthcare system to finance intervener fees and to finance this bureaucracy, this new bureaucracy that we've heard about today from Mr. Barcelona. And it's probably unnecessary, and it could in fact cause harm in the very fragile marketplace that we have today. Kaiser Permanente would prefer to spend those dollars on patient care and building and upgrading our hospitals to make them safe for our patients and our staff. In addition, we do believe that this bill could lead to price controls and rate caps that could starve the system of sufficient resources and impede access to health care. And ultimately, this proposal, as we have heard, does absolutely nothing to bring down health care costs. We have to get back to basics. There is no easy answer. As you've heard, there is no magic bullet. We need to do the hard work and have the hard conversations about how to bend the cost curve and bring down healthcare costs. Kaiser Permanente has a laser-like focus on this and will continue to do that. It will take years. It can't happen overnight. But in the meantime, as a former chair of this committee used to remind us, we must do no harm. Members, there are too many unanswered questions with this bill. There are too many potential unintended consequences that could send our healthcare marketplace into a tailspin. It's too risky. We would urge your no vote on this measure if and when a vote is taken. Thank you.
Thank you. And next.
Jody Hicks with the California Medical Association. You already heard from my colleague, but I wanted to be here as well. It's a complicated issue. We could have brought in our legal counsel too. We have very many staff over at CMA working on not only this issue, but all of the issues that it touches on. And I know Senator Rubio isn't here, but he had asked earlier for the CMA to comment on reimbursement rates. So just in addressing that quickly, you know, the reimbursement rates need to cover the cost of care. And if they don't, that's going to come from somewhere. And that's true for the plans. It's also true for the providers. So in those negotiation processes, that has to, that's a trickle-down effect where somebody's going to be affected. And for our physicians, the fear is it's the patients that will get affected the most. So our solo physicians, especially those out in rural areas, are trying to negotiate rates with the health plans. If what the regulators consider inadequate is potentially subjective or not enough for them to cover their costs, it'll trickle down to the physicians. If the reimbursement rate that they're able to negotiate doesn't cover their cost, that trickles down to the patient. So this cost shift that we're talking about is very real. And the fact that, you know, California, with these Medi-Cal cuts, will be 50th in the nation, and they're still trying to take those patients. And then on top of that, in 2014, we're going to get millions more patients with Medi-Cal. We just need to be very careful that in our striving to have affordable health care coverage, we don't take away access for patients to be able to see a provider. Thank you.
Thank you very much. Is there any questions from any of the members? Okay, next group, please. The insurers.
Good afternoon, Chair and members. Charles Bakke with the California Association of Health Plans, here in opposition to AB 52 today. We believe that this bill, as stated by others, creates a vast new regulatory structure on health insurance rates that won't work, will increase health care costs, increase litigation through the intervener process, and hamstring the successful implementation of the health insurance exchange. We understand that the public and policymakers are concerned about continued rising premiums, as we are as well. As premiums increase, it becomes more difficult for enrollees to purchase our coverage and retain their coverage. That, of course, swells the ranks of the uninsured. And clearly, our tough economic recession has challenged consumers to be able to afford coverage. Yet California's premiums continue to be at or near the national average. And this is due, as Mr. Barcelona testified in the previous group, to California's longstanding practice of health plans and providers working together through the delegated model to share risk and incentivize quality care. The new federal law actually takes a lot of these California principles and seeks to spread those across the country to try and control health care costs. The federal law also seeks to address the affordability crisis by providing subsidies for many Californians purchasing coverage through the exchange. California's individual market has been extremely impacted by the recession. This is because those who are healthy are more likely to drop their health care coverage than those who have ongoing medical conditions. And that dynamic in the individual market has been added to the cost drivers that have been mentioned before, like chronic illness, the obesity epidemic, government underpayment, et cetera. So that's why much of the attention in the media has been focused on rate increases in California's individual market, which represents about 7% of our insured market for health plans. We believe that this bill gives the Insurance Commissioner and the Department of Managed Health Care the power to set prices in the health insurance market. We believe that's a bad idea. We think it diverts attention away from the real cost drivers, which have been talked about earlier. Furthermore, we don't think that rate regulation works. A report by the California Healthcare Foundation in 2004 concluded that automobile rates went down because of fewer accidents and limits on third-party liability, not because of Prop 103. A recent article was published by the New America Foundation, which took a look at whether or not rate regulation has been effective in other states. And I'll just quote from that article from the New America Foundation. There's no systemic evidence, however, that rate increases have been lower in states with prior approval or that rate regulation is an effective tool for reining in the growth of health care spending. Clearly, health care is much more complex and critical to Californians' lives than auto insurance. But the supporters of the bill keep arguing that we should treat health care coverage the same as we treat automobile insurance. The reality is the dynamics between these two products are completely different. People aren't cars. Automobile insurance only covers costs associated with an accident or theft, which are rather discrete occurrences. Health plans pay for medical care all year long. Whether you're sick, whether you're well. We pay for routine doctor visits, daily prescriptions for medication, emergency surgeries, chronic conditions. As it's been bandied about quite a bit, 20% of enrollees drive 80% of our health care costs. And those with those chronic conditions are going to require medical care for the rest of their lives. That's just fundamentally different than getting into an automobile accident every few years. Or in my grandmother's case, maybe she was a chronic bad driver. I also wanted to talk a little bit more about the impact on the exchange. I think Mr. Barcelona raised some really good issues with bandwidth at the departments to handle all of the workload. But there's some other work that has to happen before a product actually gets to the regulator for approval. And that's between now and 2014. The exchange at some point is going to be ready to reach out to health plans and insurers and start talking about what coverage is going to be provided in the 5 tiers. There's going to be time that's needed to develop those products, to decide whether they're going to be standardized, whether there's going to be a lot of variation within the 5 tiers. And then they're going to have to contract with us to design them, price them, and offer them for coverage. We think that AB 52 actually undermines the exchange's ability to do that because it gives 2 regulators who are not seated on the exchange board veto authority over the work of the exchange. Because if you read AB 52, it defines rates as not only premium rates, but also copays, deductibles, and other out-of-pocket costs, all decisions that the exchange will be making in partnership with plans over the next 2 years. We also believe the bill will create great uncertainty for carriers that want to contract with the exchange in 2014, and they will have a lack of confidence that any premiums that they develop with the exchange in 2012, 2013, 2014 are going to ultimately be approved by the regulator. In addition, if you look at the intervener process and the judicial process and the mechanics of what's in AB 52, it creates an extraordinarily long process for a plan to get a product improved, and that will include plans offered in California's Health Benefit Exchange. By my estimates, I walked through the bill and I timed it out. I think that it could take at least a year and a half for a planned product from the date it's filed, if it is intervened and there is a public hearing and it goes through the judicial process, for it to have a final decision on it. So when you back up the 2014 date for the exchange to be up and running, you can see that plans could very well be trying to price products for the exchange almost 2 years in advance of January 1st of 2014. Our concern is that you're going to have insurers and an exchange board trying to estimate premiums when not only do we not know how a medical trend is going to go over those 2 years, but we don't know a lot about what the federal government might say that might change those trends. This could lead to a lot of mistakes and errors in pricing and a very disastrous first year for the exchange. So for those reasons, we think that the legislature should be very cautious in moving forward in something like this. You know, there's been a lot of talk about insurance profits, and fortunately I don't have to give my whole testimony because a lot of them were discussed here. I'll just leave it at, you know, we have one of the lowest profit margins in the healthcare sector, and I think that is a red herring, quite frankly. I did want to address some comments by the author and sponsor about Massachusetts and the connector and rate regulation and how they work together. You know, Massachusetts actually instituted a rate freeze at one point with its prior approval authority. The governor was up for re-election. He froze all the rates in the insurance market in Massachusetts. It created quite a mess. Ultimately, at the end of the day, the plans got premium increases, but they do have prior approval of rates in Massachusetts. But my understanding of the marketplace there is there's actually a very, very small percentage of the enrollees in the connector are actually subject to prior approval. So I don't think you can say that just because Massachusetts has prior approval of rates and it has a connector, that those two work well together. The connector in Massachusetts came first. Here we're talking about having rate regulation in effect before the exchange is in effect. And by my back-of-the-envelope math, I think it's something like 15% of Massachusetts' connector population is actually covered under rate review. That's because all the subsidized products are not subject to prior approval in Massachusetts. On the return on equity discussion, I thought that was very interesting. I myself have been struggling with what it means. Here's from Wikipedia with citations to financial experts. Return on equity measures the rate of return on the ownership interest of the common stock owners. Return on equity shows how well a company uses investment funds to generate earnings growth. A return on equity between 15 and 20% are considered desirable. High return on equity yields no immediate benefit, since stock prices are most strongly determined by earnings per share. I don't know what that means, but I'm not sure the author and sponsor do either. I worked for the Chamber for almost 5 years, and I'd never heard a business talking about its great return on equity. I know it's something Wall Street uses, but I just don't understand it. So clearly there could be more discussion about that. Mr. Barcelona cited some internal survey work that we did with our member plans about the workload created by this bill. And just to clarify, we surveyed our 7 large commercial plans on how many product filings they would believe they would need to file in 2012 under AB 52. Only 5 plans responded, so I'm missing quite a bit of data there. Those plans responded that they believe 16,191 products would need to be filed. So that leaves out 2 other commercial plans. It also doesn't include a decent number of small and regional health plans who are members who we were unable to survey. For comparison, as the insurance commissioner noted, the Department of Insurance currently processes around 8,000 Prop 103 filings. So this is twice that workload. The 2010 annual report by the Department of Insurance stated that the Rate Regulation Department spent between $25 and $30 million to process those 8,000 rate filings. So I think my $16,000 number, 16,000 product number is low, and clearly doubling the department's workload would get you $30 million or more to handle it.
I believe Senator Strickland had a question.
I just have a close, and then I'm finished. So, I think the question really for legislators and policymakers is what can we do to help control healthcare costs instead of passing this bill? And I think, you can promote transparency efforts in our healthcare system like Senator Hernandez and Senator Gaines' SB 751. You can monitor the rate review process and the medical loss ratio and how that impacts our market this year and next year. We can make sure that the health insurance exchange gets up and running on time and gets people the subsidies that they need right as soon as possible. And you can address, trying to provide the capacity for our providers to handle the millions of new enrollees who are going to be covered by public programs and private insurance in 2014. We want to be a constructive partner in those discussions on how to control healthcare costs and improve our healthcare system. We believe that this bill will actually undermine it. So we therefore ask for your no vote.
So to follow up on your testimony, I'm going to ask you some of the same questions I asked Mr. Barcelona. In your opinion, does rate regulation control utilization?
No.
Cost of technology?
No.
Medical rate of inflation?
No.
General inflation?
Well, of course not.
Okay, so if prior approval doesn't control these underlying costs of health care and the rising cost of health care, how does it reduce the premiums moving forward?
Well, the only way it could possibly reduce the premiums if it was arbitrary and you were to actually just freeze rates like they tried in Massachusetts.
Or rationing?
Or, yeah, ultimately, if plans are not provided enough premium to cover their costs, first goes profit, second goes reserves, and somewhere in there are negotiations with our contracted providers through the delegated model. Something's going to have to give with those contracts. We'll have to reopen them. That's ultimately what started to happen in Massachusetts when they froze rates. The plans went back to the hospitals and said, we're going to have to slash your contracted rates, which created a huge outcry. It's interesting to note that now in Massachusetts, that has prior approval of rates on health plans, they've decided that isn't enough, and they're now considering prior approval of hospital costs in Massachusetts.
Well, in my understanding, the hospital side is the ER visits almost doubled, nearly doubled.
I haven't taken a look at that.
Okay, next, please.
Thank you. Ann Eowan with the Association of California Life and Health Insurance Companies, and I just want to thank the chair and the committee members for your patience and just giving us an opportunity to fully and fairly discuss these issues. ACLIC is opposed to the bill for many of the reasons that Mr. Bakke mentioned. I think what I'd like to do with my testimony, rather than repeat what he has said, is perhaps dig down a little bit into why we are concerned about the process that's in AB 52, why we think it will impact workload and the ability to get products approved in advance of the exchange, and then just talk a little bit perhaps about what we currently have and why we think that ought to be given a chance to work. AB 52 has been compared to Prop 108, but there are some significant differences. One of those is that there is no definition in the bill of what is adequate, excessive, or discriminatory. Rather, companies are required to file, I think, 18 or 19 data points with the department, and then the department, without any direction in the bill in terms of how they might weight that information, is to come up with a determination that those rates might be inadequate or discriminatory or excessive. That's a major concern to us in terms of what criteria both departments would be using to determine that. And so there's nothing in the bill that would give them any sort of direction in terms of that. They would adopt guidance for the first 6 months without the benefit of a public hearing or under the Administrative Procedures Act, any of that due process to maybe flesh these things out. But there's nothing in here to give the members of this committee or the industry any direction on that. In addition, under the current rate review process, there is a focus and an emphasis on actuarially sound rates. In AB 52, that's just one thing that the department can consider, but it's certainly not weighted, and they can decide that that's not relevant to their ultimate determination. So that's a major difference and a concern. We're also concerned about the fact that I actually did my own back of the envelope trying to figure out how long this process might be, and I come up with something far longer than Mr. Bakke, because in the bill, companies are required to file their premium rates within 60 days of implementing them. Now, unlike Prop 103 and unlike the rate review process, we are now having to file any copay change, whether it changes the ultimate premium or not, any cost sharing in the product. If you look at what you have to do, you have to, anytime you want to make any moving part that might have a cost impact on the insureds, you have to file that for review. So that's a big major difference as well, and a big major difference from the rate review process. While filing all of these multi-products for review, they have to do it 60 days in advance. There's no time period for which the department would have to file this information publicly, but once it is filed publicly, then the 60-day calendar would tick that the Commission was talking about, that they would review it. Of course, as he mentioned, there's no deemer, there's no requirement that he completed in that 60 days. However, if a hearing is requested, and there's a number of criteria as to how a hearing might be requested in the bill, if a hearing is requested by anybody, including an intervener, then there is no requirement that there be any time frame during which that hearing has to take place. It could take years. Once a hearing has taken place, then the department has to render its decision within 100 days. Now, all of this comes at the heels of all the products that have to be filed to meet the new requirements for essential benefit packages. You can't file rates until you have those products approved. During the last go-around with the changes that the ACA made, there were 2 department staff persons in the Policy Approval Bureau that looked at that. I don't know if the department has beefed up their Policy Approval Department, but we are talking about lots of product approvals that would have to go in. Policy approvals are different than the rates associated with that. That's 2 separate processes. This is why we're concerned from a process standpoint that this is going to be a huge backlog and that there won't be the products available for the exchange in time for the exchange, and certainly not in time to make the necessary negotiations with the health plans. So there are some serious issues here that need to be addressed. We also are very concerned that this is in advance of what we'll probably get from the exchange, and also before we've really gotten to see, as Mr. Bakke mentioned, how rate review works, because under rate review, the department is the ultimate authority in determining whether or not they agree with the actuarial assumptions or not, but at least it's based on an actuarial assumption and not some standard that is yet undefined. And so we would like to see that process work. Right now it seems to be working. Companies are reducing the rates that they file, and we'd like to see that work before we go to something as draconian as this that will ultimately lead to all of the downsides that have been mentioned here today. So we would ask for a no vote when the bill.
Thank you. Next.
Mr. Chair and members, Maureen Higgins representing America's Health Insurance Plans. I'd like to incorporate by reference the comments of my other 2 colleagues in the interest of time. I just want to make 2 quick additional points. Ms. Eowan was just talking about the current rate review process and that it's based on actuarially sound principles by an independent actuary, which buffets it from the political process. I would just add that it also meets all of the federal requirements under the Affordable Care Act for an effective rate review process. The federal government just recently, May 24th, adopted rules under which our rate review process would meet. In fact, our process is actually stronger than the federal process, because the federal process only requires a filing and review of rates if they're 10% or greater, and the SB 1163 process requires a filing and review of all rates. My second quick point is that over the next couple of years, we're going to see a lot of changes to our market because of the Affordable Care Act. Everything from guarantee issue, which deals with the pre-existing condition problem, to community rating, to product changes with the essential benefit package definitions coming out hopefully by the end of the year by the federal government, full implementation of federal MLR requirements, et cetera. I think the chair in this committee actually wisely deferred a decision on the essential benefit package because he wanted to make a deliberative and careful choice about avoiding unintended consequences, in that case, possible state costs if we exceed the essential benefit package. Others have talked eloquently about the potential for conflict with the exchange that has a lot of work to do to build the exchange by 2014, has just had its 5th member appointed, and we want to avoid conflicts and unintended consequences there. I think the representative from Kaiser made the point very, very well about being careful and avoiding those comments. We would agree, and so for that reason, we oppose the bill.
Thank you. Next.
Mr. Chair, members of the committee, I'm Gene Livingston on behalf of State Farm. You were told today that Prop 103 is a model for AB 52, And in fact, you were also told that Prop 103 has saved consumers billions of dollars, and one witness opined that it was $62 billion. It is true that from the passage of Proposition 103 in 1988 up until the present time, rates dropped. But they began to drop in 1997. And you may ask, well, why did it take nearly 9 years for rates to go down if Prop 103 was so significant? But the answer to that question is that Prop 103 had nothing to do with the rate reduction. And in fact, the reality is that Prop 103 probably cost consumers billions of dollars during that time period. And to explain that in a little more detail, let me go back and provide a little bit of legal history. In 1979, the California Supreme Court allowed third-party claimants to bring lawsuits against insurance companies for what were known as bad faith claims, for violating the Department of Insurance regulations on unfair business practices. Prior to that time, that was solely a matter for enforcement by the Department of Insurance. Now you had an insurance company who's trying to defend its insured on one hand, but if it delays a settlement, or if it doesn't conduct or respond quickly enough to the plaintiff's counsel, then the insurance company is subject to a lawsuit, and not just a lawsuit for damages, but for punitive damages as well. And those cases were yielding to plaintiff's counsels multiples, millions of dollars, well beyond the amount of the underlying claim. So insurance companies now found themselves caught in this horns of a dilemma. And the natural response to that was to pay claims that were questionable, to pay a higher amount to settle those claims and get rid of them quickly to avoid that second lawsuit. What happened in the years following the Royal Globe decision in 1979 was that the number of auto lawsuits filed in the state of California nearly doubled, that the payouts that California insurance companies were making went up 250%, and fraud increased dramatically. The fraud index in California was 2.3 in comparison to the national fraud index of 1. What happened then in 1988 is the California Supreme Court took another look at this issue and said, we blew it big time, that was a bad decision, and it reversed Royal Globe in a decision called Murati Shalal. It took about 3 years for the Royal Globe cases to work their way through the system. Beginning in 1991, claims costs began to drop. In 1989, prior to claims costs dropping, this legislature passed stringent anti-fraud legislation to bring down some of the fraud that had resulted from Royal Globe. In 1992, this legislature authorized primary enforcement of the seatbelt laws. California had the highest compliance rate of any state in the country, and the National Highway Traffic Safety Administration points out that the cost to treat a person who's injured in an automobile accident who is belted in is 60 to 80% lower than the cost to treat a person who is not belted in. In addition to that, what we're starting to see then is reduced claims being filed, reduced severity, and claims costs dropping. But rates remained steady. They did not drop. Claims costs dropped, as I said, beginning in 1991, but not premiums. Premiums did not begin to drop until 1997, and the reason for that is that in 1996, the people approved Proposition 213, which eliminated the right of uninsured drivers to recover non-economic damages. That, again, reduced the amount of payouts that insurance companies were making in auto claims. It was not until then that insurance companies began to believe that, in fact, claims costs were going to be reduced on a permanent basis, and they began to lower their premiums. One economist, a consulting economist, Milliman Inc., in a 2004...
Do you mind if I ask if we can just keep it germane to healthcare? Because I appreciate the history. I do appreciate the history of the auto insurance industry, but if we can kind of shorten it just a little bit. Thank you.
Right. The question is whether rate regulation saves consumers money or not. And the conclusion of the Milliman company in 2004 was that Proposition 103 probably dissuaded insurers from taking rate decreases more promptly, as they likely believed that subsequent rate increases would be hard to achieve. We estimate that such regulatory lag cost California consumers billions of dollars. So rather than being a benefit, it was actually a detriment to consumers.
Thank you. Next.
Natalie Cardenas with Anthem Blue Cross. In the interest of time, we oppose the bill for the reasons already stated. Thank you.
Thank you. Next.
John Latimer on behalf of United Health Group. I associate myself with the earlier comments of my compatriots.
Thank you. I believe we're now to the last section of the opposition. And was there anyone else like to come up and oppose?
Good afternoon, Mr.
Good
Chairman.
afternoon.
Julianne Broyles here on behalf of both the California Association of Health Underwriters and the California Association of Joint Powers Authorities. You've heard a lot of testimony this afternoon, so I'm going to certainly align myself with some of the points that were brought up, particularly by Mr. Barcelona and Mr. Bakke in prior testimony. But a couple of points we would like to make. On behalf of the California Association of Joint Powers Authorities, the concerns that we have had deal with AB 52 deal with the whole process in AB 52 that could delay the open enrollment. These are risk management JPAs. They provide health care coverage for cities, counties, school districts, libraries, and others. And they go through a process where they have to get rate information because they self-insure for this process, rate insurance from their underwriters, usually in December. By March, they have to have at least a preliminary data on the claims history to their underwriter, back from their underwriter on the trend of their claims history, their migration factors between plans and other factors, and then get it to their boards in time for their May vote to approve whatever program that they have chosen, and then have that available to their employees for open enrollment prior to the July 1 start of their fiscal year. It is a concern when you have a really open-ended process where you have 60 days prior to using a rate that you have here in AB 52 that then can be challenged in an intervenor process or by other people asking for a public hearing. We don't think we could ever conclude our open enrollment process in a timely fashion under the auspices of AB 52. We think that also that there is some other additional problems within setting any change in our cost of levels of service or levels of benefits within our programs that we offer to our employees, because again, we might have come to a good faith resolution and agreement with our unions on reasonable changes in those levels of service or copays or deductibles, and all of those agreements could be for naught if one person brings up a challenge to a rate plan and a change in plan components, and then have to wait for months and months and months before we could even put it into place. For the California Association of Health Underwriters, they have the same concerns that the plans do over having excessive rate regulation, and would ask for your no vote on the bill.
Thank you very much. Next.
Jennifer Barrera on behalf of the California Chamber of Commerce, and we are also opposed to AB 52. It is labeled as one of our job killers. We have 15,000 members. 80% of them have less than 100 employees, so there's a lot of small businesses that are concerned with this. And our concerns are similar to comments already made, so I'll be very brief with my testimony as well. We're concerned that the rate regulation doesn't necessarily address the primary reasons for the rising health care costs. And until those are addressed, we don't think that this is a fix to the problem. Also, because of the unintended consequences that have already been mentioned, we're concerned with being if you artificially suppress these rates, it's going to be made up somewhere else, meaning less quality and quantity of care for the employees. So we're concerned with that as well. We're also concerned with litigation expense and fees that this could be borne on the health care insurance plans, which will ultimately raise costs as well and will have to be borne somewhere. And for those reasons, we're opposed.
Thank you. Next.
Catherine Pettibone with Civil Justice Association of California, representing one of the organization that drafted Prop 64, limiting abusive lawsuits brought on behalf of general consumers to those who are injured in fact. We are very concerned with the private intervener rights in this bill. We believe it will create a cottage industry for some of the proponents. As noted, it has resulted in significant amounts being awarded these organizations, advocacies, expert fees, and other costs. And since it was mentioned, I was rethinking my career choice since one of the founders of these organizations earns $640,000 a year. This is a profitable industry, and we are concerned that it will be abused, and then these fees will then be passed on to the healthcare providers and insurance groups, and then those will be being put into the premiums. For these reasons, we're opposed.
Thank you. Next.
Good afternoon. Clara Evans with Catholic Healthcare West. Catholic Healthcare West is the largest private provider of Medi-Cal services in the state of California. We, too, are opposed to this bill for many of the same reasons discussed by my colleagues, primarily the fact that it doesn't really address the increase in health care costs. It really does take away our ability to negotiate with private payers. And also because we believe that it will have a chilling effect in the implementation of the health benefit exchange. And for those reasons, we oppose. Thank you.
Thank you. Next.
Good afternoon. My name is Michael Faust. I'm here representing the Sacramento Metro Chamber. We're the second largest chamber of commerce in the state of California with more than 2,000 members. Over 90% of them are small and mid-sized businesses. We are strongly opposed to this bill for many of the reasons previously stated, but we do believe that the federal health care bill should be given time to implement. We think AB 52 will jeopardize a successful implementation of that. We also are very concerned that it creates an expensive bureaucracy that will divert millions of dollars that should be actually going to patient care instead of the implementation of AB 52. So with that, Sacramento Metro Chamber strongly opposed to AB 52 as drafted.
Thank you. I believe Senator Strickland had a question.
I just had a question for the lady from the Catholic Healthcare West.
Sure.
If rate regulation of this bill moves forward, what kind of impact would it have on the seismic safety repair costs that are moving forward that you have to abide by?
I mean, we walk really a fine line in our ability to continue providing services to the extent that we are. I'm not the appropriate person to ask within my organization. I would say that, you know, there's a fine balance, and tipping that balance, you know, there's a lot at stake.
So you believe that there could be an impact on you moving forward on the seismic safety issues if this bill is passed?
Like I said, I'm not the right person to speak to that. What I can say is we provide as much Medi-Cal as we can within the communities we serve, and we try to balance that out with the requirements that we have to adhere to. So I can't say that, you know, whether or not it will affect our ability to meet seismic compliance any more than I could say we would pull back on Medi-Cal.
Okay, thank you.
Thank you. Next.
Good afternoon, Mr. Chairman and members of the committee. I'm Brian Little, representing the California Farm Bureau Federation and farm families and farm employers from across the state. I'd like to associate myself with the remarks offered by my colleague from Cal Chamber and request your no vote on this bill. Thank you.
Thank you. Next.
Bless Shepard, representing the Silicon Valley Leadership Group in opposition.
Thank you. And it looks like that ended the testimony for support and opposition. As you can see, it's an extremely difficult issue. That's the reason why I wanted to take this time. I know it was long, lengthy. A lot of my questions were answered. I still have a few more. What I'll do is I'll allow you to make some closing remarks, and then I'll make a statement. And then, of course, this is informational only, and we will hold this for a vote next week. Assemblymember Fuhr, thank you.
Given the hour, Senator, I'd be interested in hearing your closing comments. Obviously, very strongly urge support for a bill. And again, I think that the point at the end of the day is, would Californians be better off the day after this bill is signed? I think there's ample evidence to support the fact that they would be. I urge your support.
Okay. I agree. We have a problem. We have escalating healthcare costs. But there was, and I also agree, and we've had this discussion, you and I, as well as the commissioner, that this is not going to solve the healthcare crisis that we have. But there was one thing that was never really brought up, and I was trying to listen and it's what's causing the increased healthcare cost. I mean, if you look at what we as government have done, and obviously one of the reasons why I held the mandate bills is to make sure to figure out what the essential medical benefits were, because I would venture to say that in 2014, costs are naturally going to go up because of the essential medical benefits. We have over 50 mandates that we have to reconcile with the federal government that we could potentially in the state of California have to pay. That's going to incur the cost. We have unfunded mandates that we're given to the hospitals that require them, and that goes into healthcare costs. So I believe there is going to continue to be healthcare costs. We need to control them, but I also believe that we need to look at efficient ways, like what Mr. Barcelona said, with how we're going to implement our ACOs, how we're going to look at a medical home model, how we're going to look at electronic medical records, how we're going to look at eConnect. There's a lot of efficient ways, and if I'm going to take a position on this bill, I'd like to interject some of those issues into it. And, maybe we need to look at transparency and look at how we're going to make sure that these insurance companies or the healthcare industry explains where those costs are so we can address them in a more efficient manner. So, I mean, this is extremely difficult. I still don't know where I'm going to come down on it. I have some problems with the current version of where the bill is. I will share with you. You and I will sit down and I will propose some amendments, and then hopefully we could come to some kind of an agreement, and hopefully I can be supportive of the measure.
I look forward to that opportunity, Senator. Thank you.
Thank you. And thank you, Commissioner Jones, for being here. I appreciate your time and effort, and for your testimony as well. If you'd like to just make a statement.
Only, thank you, Mr. Chairman. Thank you, Senator, for your diligent attention to the issue. We look forward to working with you. Thanks,
Thank you very much. We have, let me just make a couple of announcements. We've had some bills pulled. Let me state those bills. Item number 4, AB 540. Item number 5, AB 574. Item number 8, AB 784. Item number 10, AB 861. Item number 12, AB 1059. Item number 15, AB 1297. Sergeants, will you call the members, and also will you call the authors? Most, if not all, of the remaining bills, I believe we have 9 bills left. Very few have any opposition. What I'm going to do is ask the authors to make opening statements and just ask the supporters just to state their name. I can't discourage any questions, but if there's no opposition, I would encourage that we try to move this along and get out here as quickly as possible, considering that there is no oppositions to the majority of the bills. I believe we have an author, Assemblymember Logue, I see. And we're in item number 3, AB 415, Healing Arts Telehealth. Assemblymember, welcome, and you're the first bill we're going to be hearing this afternoon.
Thank you, Senator. I appreciate that. Excuse me. See, AB 415 is the Telehealth Advancement Act of 2011 and is sponsored by the California State Rural Health Association. This bill will remove barriers in current law to use telehealth and will bring the law up to date with the current practices of healthcare. Advancing telehealth will cut costs, increase access, improve the quality of care. This bill is supported by a wide range of stakeholders in healthcare and has received no votes. We will be taking amendments on AB 415. A mock-up of these changes and documents explaining why each amendment was taken should be in front of you. These amendments are the product of negotiations with the providers, health plans, insurers, and should address all remaining concerns. If you have any questions, I have experts here. Steve Barrow with the California State Rural Health Association and Angela Gillard with the University of California Health Assistance. This has also been endorsed and co-authored by Dr. Pan and Assemblyman Manuel Perez. Mr. Barrow.
Thank you, Assemblymember Logue. My name is Steve Barrow. I'm the director of the California State Rural Health Association. I'm just going to make a couple of remarks because you've been here a long time today, and we have a lot of experts if you have questions to answer all the questions. The reason is obvious.
What I like to, if you don't mind.
I would like to move the bill.
Okay. My understanding, this bill has no opposition. If there's no opposition, I really would appreciate if you can just state your name and your position. And I don't anticipate there's going to be very many questions. This way we can just, if you're okay with
We're
it.
responsible
Thank you.
bill.
Thank you.
Angela Gilliard, representing the University of California Health System, in support of the bill.
Thank you.
Eric Brown, President and CEO of the California Telehealth Network.
Thank you very much. How's the golf going?
Barbara Glazer with the California Hospital Association, in support.
Thank you.
Jennifer Simoes with the Medical Board of California, in support.
Thank you.
Dean Grafilo with the California Medical Association, support this measure.
Thank you.
Christy Weiss on behalf of the Local Health Plans of California, in support. Thank you.
And David Gonzalez on behalf of the California Association of Physician Groups, in support.
Thank you.
Kathy Mossberg on behalf of the Public Health Institute, in support.
Thank you.
Kathleen Hamilton with the Children's Partnership, we're in support.
Okay, thank you. I'm assuming there's, from my records, there is no opposition. My understanding, this is due pass to business, professions, and economic development. Obviously, with the understanding those amendments will be taken there. They are here in mock-up form. There has been a motion by Senator Strickland. I'm assuming there's no questions? No? Secretary, call the roll.
Senator Hernandez?
Aye.
Hernandez, aye. Strickland? Strickland, aye. Alquist? Anderson? Anderson, aye. Blakesley? DeLeon? DeSaulnier? Rubio? Wolk?
That has 3. As you can see, we have members still absent. We will put that bill on call and lift the call when the rest of the members are here. Assembly member, and thank you very much.
Thank you, Mr. Chairman.
Just another announcement. AB 688 has also been pulled. Item number 6. Okay, I believe, who was first? I don't. If you're first, I just didn't see who came in first, and I didn't want to call a name without. But Assemblymember Atkins, I believe we've got item number 7, AB 714. Is that correct?
Yes, Mr. Chairman, that's it.
Well, good afternoon. Welcome. You are the second author and presenter. We have had a long hearing.
Yes, I've listened to most of it, Mr.
And
Chairman.
Please proceed.
Thank you. I'm here to present AB 714, and I want to thank you and your committee staff for help in improving this measure. And I'm happy to take, as the author's amendments, the issues raised in the analysis, which are on pages 7 and 8, and I'm prepared to point all those out if you want me to. We are passing out the mock-up. And since we are double referred to the Senate Judiciary Committee, we'll be adopting those amendments in that committee next week. And I assure you we will do that and take those up. There are a few things, and I could go through it if you want me to, but basically the substance of the measure is what I would like to focus on. Federal health reform will benefit California more than any other state, and today an estimated 7 million Californians are uninsured. UCLA estimates that almost 5 million of those 7 million will be eligible for coverage in 2014. And today, more than 3 million Californians are linked to various public programs that provide partial coverage or that end when someone turns 18 or otherwise loses eligibility. A partial list of those includes family members of kids on Healthy Families, public programs like AIM, breast and cervical cancer, prostate cancer treatment, and Family Pack. A couple of high-risk pools, kids on Medi-Cal, and Healthy Families who lose eligibility when they turn 18 but will again be eligible in 2014. We do think if we start now, on January 1st, 2014, we can enroll between 2 million and 2.5 million of these Californians in coverage through the exchange or Medi-Cal by pre-enrolling them. So the last thing I would say, just to clarify what AB 714 does to get these people enrolled. In 2012, it provides notice of the availability of coverage in 2014. In 2013, in addition to notice, it requires the existing public programs to provide to the exchange the information that the exchange will need to determine eligibility so that the exchange can begin the process of enrolling people. Then on January 1st, 2014, when we flip the switch on health reform, almost half of the uninsured Californians who will be newly eligible for coverage will be enrolled in coverage. So I have with me today, Mr. Chairman, Beth Capel on behalf of Health Access California and Elizabeth Landsberg on behalf of Western Center on Law and Poverty. Probably, or maybe not, some other witnesses, but we're happy to take your questions and comments if you would like.
Yes, thank you. We do have opposition. This is the California Right to Life Committee, so I will allow testimony and support. What I appreciate, if we can just limit it to 2 individuals at 2 minutes each, and then the rest just state your position. Thank you. Proceed.
Beth Capel on behalf of Health Access California. As Ms. Atkins has described, this bill, we believe, would enroll on January 1st, 2014, between 2 and 2.5 million Californians who are already linked in some way to a public program, and thus really jumpstart health reform and get those Californians the coverage they need. We want to thank you, Mr. Chair, and your staff for working through the amendments with this. This is a first-in-the-nation bill. Nobody has ever tried this before, and so getting it right has taken a lot of fine technical work, and we also appreciate our other allies. Thanks.
Thank you. Next.
Mr. Chair and members, Vanessa Kahina on behalf of Health Access, Western Center on Law and Poverty. Long day. Anyway, we'd like to concur our comments with those of Ms. Capel. We think this is a good bill. We want to get California to a just press play kind of place on January 1, 2014. We ask for your aye vote.
I was going to say, I didn't realize you just started working for Health Access. Next.
Gary Passmore with the Congress of California Seniors urging your aye vote.
Thank you. Next.
Juan Thomas with the California Medical Association in support of the bill.
Thank you. Next.
Randy Hicks with Older Women's League of California in strong support.
Thank you. Next.
Allison Lobb with California Coverage and Health Initiatives in strong support.
Thank you.
Kathleen Hamilton with the Children's Partnership and the 100% campaign. We're also in support.
Thank you.
Kathy Mossberg, representing the California Family Health Council, in support.
Brianna Pittman with Planned Parenthood Affiliates of California. Also would like to thank the author and sponsor for bringing forward this bill and for working with us and stakeholders.
Thank you.
Alicia Sanchez with the American Cancer Society in support.
Consumers Union in support.
Thank you.
Ana Quiros on behalf of the Latino Coalition for a Healthy California in support.
Thank you. Next. Opposition. Assemblymember, I want to thank you for working with the committee, taking the amendments. You addressed my concerns, especially with regard to the opt-in, the opt-out. I believe Assemblymember Bonilla also took similar kind of amendments. I want to thank Health Access because it's very important that we make sure that the health insurance exchange is effective upon its inception. With that, I'd like to ask that you close.
Thank you, Mr. Chairman. And in light of the time, I would just, again, thank you for the work you put into this and your staff and ask for an aye vote.
Okay, thank you. We have a motion to move the bill by Senator Woke. This is due pass to judiciary with the understanding that the amendments will be taken there. Amendments have been passed out in mock-up form. The chair will be recommending an aye vote. Secretary call. Yes, Secretary by Senator Woke. Secretary, call the roll.
Senator Hernandez?
Aye.
Hernandez, aye. Strickland? Strickland, no. Alquist? Anderson? Anderson, no. Blakesley? DeLeon? DeSaulnier? Rubio? Wolk?
Aye.
Wolk, aye.
That has 2-2. As you can see, there's members still absent. We will put that bill on call and lift it at a later time. And thank you very much, Assemblymember, for the time. What's that? I believe Assemblymember Bonilla was first. Is that correct? I know, even though we were in sign-in order, are you, or file order, I mean? Are you okay with that, Assemblymember Williams? Okay. Okay, we're on item number 9, Assemblymember Bonilla, Healthcare Coverage, California Health Benefit Exchange.
Yes, thank you so much, Mr. Chair and members. First, I'd like to thank the chair and the committee staff for their help in refining this measure, and I'm happy to take as authors amendments those included in the mock-up that's being handed out right now. And I commit to continue to work with the chair and the committee staff on any remaining issues. AB 792 builds on and improves federal health reform and the work done last year in creating the California Health Benefits Exchange. The studies show that half of the uninsured are uninsured for less than a year, tending to losing a job, a divorce, losing a spouse, children turning 27. COBRA works for roughly 20% of those eligible for COBRA, partly because the same event that causes you to be eligible also reduces your income very dramatically and puts insurance out of range. This bill creates an alternative to COBRA by initiating an application for enrollment, and that's why we're calling it a pre-enrollment into the exchange process. And it's a way to notify people who are losing their coverage because of these life-changing circumstances that the exchange is there for them and that they can proceed with the process of getting into the exchange and getting health coverage. AB 792 also helps those who are buying individual coverage in two ways. First, almost 60% of those who buy individual coverage today will be eligible for the exchange or even Medi-Cal. So this bill provides them notice about the reform. And second, for those who lose individual coverage, this is an application to the exchange, and that process would be initiated with this bill. How would it work? People who lose coverage would get a notice about the availability of this coverage, and their information would be provided to the exchange to then initiate the process of enrolling in coverage through the exchange. No longer would losing your job mean automatically losing your coverage. Instead, you could stay covered when you were between jobs, recently divorced, or turning 27. With the Affordable Health Care Act implementation rapidly approaching, it's time to move forward to create mechanisms to maximize consumer enrollment in health care coverage. And this would, of course, ensure the seamless coverage that we're attempting to achieve. And I do have Beth Capel here from Health Access to speak on the bill.
Beth Capel, on behalf of Health Access California, again, we'd like to thank the chair and your staff for your work on this bill in helping us to craft it. It's an important measure, and again, a first-in-the-nation measure that recognizes that, as Ms. Bonilla said, that half of the uninsured are uninsured for less than a year. We're going to... With the implementation of health reform, we will be in a world in which people go from employment-based coverage to the exchange, to individual coverage, back to employment-based coverage. AB 792 and on to public programs and to the exchange. AB 792 is one of a number of measures designed to help smooth those transitions and make sure that people remain covered. The academic literature is very clear that people who are without coverage, even for brief periods of time, have worse health outcomes and are at risk of financial catastrophe. I cannot tell you how many stories we have had of somebody who has the heart attack or the appendicitis just when they're uninsured. Thank you.
Thank you. Next.
Elizabeth Landsberg with the Western Center on Law and Poverty, in strong support of the bill to maximize coverage in the exchange and Medi-Cal. Thank you.
Thank you.
Gary Passmore with the Congress of California Seniors urge your support.
Thank you. Next.
Allison Lobb, California Coverage and Health Initiatives, in strong support, also on behalf of the 100% campaign.
Thank you. Next.
Juan Thomas on behalf of the California Medical Association in support of the bill.
Thank you.
And Randy Hicks is an individual who faced this same situation. Lost my job, lost my health care, tried to go into COBRA. We need this.
Thank you. Next.
Betsy Umholtz from Consumers Union in strong support.
Thank you. Is there anyone else in support? And is there opposition? Please state your name.
Mr. Chair, members, Stephanie Watkins on behalf of the Association of California Life and Health Insurance Companies. I'd first like to thank the author and the sponsor. We had a very productive conversation yesterday about the mock-up amendments. Unfortunately, we still remain opposed to the bill and have significant concerns with respect to the idea that we would have to get consent from our insureds to process and transfer the information. And specifically, the bill requires us to obtain written consent from our insureds upon a qualifying event to forward the information to the exchange and initiate enrollment. Yet it's unclear what that process would look like, what would constitute sufficient attempts on behalf of the plans. We're also concerned with respect to the idea that upon 2012 we would have to start to warehouse this information. So it's the concept that we would have to create an IT system, a structure to qualify, to track the qualifying event, to track the attempts to gain consent, also to process and warehouse the information and transfer it as late as 2014 to the exchange. Some of that information will be 2 years old, and so there's a concern with respect to transferring that information and it being stale and not usable by the exchange. We also run the risk that that we don't meet the obligations to our regulators of attempting to get sufficient consent. We also have concerns in the individual market with respect to sending out notices when we no longer have a relationship with the insured. Sometimes they come back. There's a 30-day grace period for which they can come back and pay their premium, but we would be sending them information about moving them over to the exchange, and we have concerns with respect to that.
Thank you. Next.
Charles Bakke with the California Association of Health Plans. I also want to thank the author and sponsor for several meetings we've had. I think it's important to note that we agree with the general concept of the bill of trying to find a way to help people who've lost their health insurance access coverage in the exchange. And so we've had conversations about narrowing the bill. The amendments that are being taken up in mock-up here today do narrow the bill considerably. Unfortunately, we, as Ms. Watkins testified, have problems with the mechanics of that. We think there might be a way to more cleanly, in this first year, look at the existing COBRA notification as a good trigger for providing the enrollee information about the exchange. But we're very concerned about once we own the collecting of the information and forwarding it on process is a significant concern for us. So we applaud the author and sponsor for what we think is a good idea. We're having difficulties with the mechanics. We'll continue conversations with them. We appreciate the work of your staff, Mr. Chair, on this as well. Thank you.
We're Next.
Opposed.
Good afternoon, Mr. Chairman. Senators Julianne Broyles here on behalf of the California Association of Health Underwriters. Certainly we agree with the points brought up by Ms. Watkins and Mr. Bakke, but we also have had conversations with the sponsor and with the author's office and appreciate their goal. And as it was expressed to us, the goal of the bill in our conversation was to deliver the enrollee to the door of the exchange, but not require them to walk through it. And that's something that we actually can get behind. Again, with the mechanics, we're not sure that we're there yet, because the exchange itself, once it is fully up and operational, could have a wide variety of programs for that enrollee. However, with just basic information, you're not going to be able to transmit to that potential enrollee all of those different options that might be out to them. And we think that, again, it kind of ignores the role that agents and brokers have in this process. So we would like to continue to work with the Assembly member. We'd like to continue to work with the sponsor, but right now we're just not there yet and must ask respectfully for no vote.
Thank you. Anyone else in opposition? I'd like to also thank the author for considering the opt-in and opt-out provisions. My understanding that this will be a due pass to judiciary with amendments to be taken there.
Yes.
We have the amendments here in mock-up form. The chair will be recommending an aye vote and supporting it.
Move the bill.
Assembly member, we have a motion.
As amended by the chair.
As amended, Senator Wolk, please close.
Respectfully ask for your aye vote.
Thank you. Secretary, call the roll to due pass to judiciary.
Senator Hernandez?
Aye.
Hernandez, aye. Strickland?
No.
Strickland, no. Alquist? Alquist, aye. Anderson? No. Anderson, no. Blakesley? De Leon? DeSaulnier? Rubio? Wolk? Wolk, aye.
That has 3-2. As you can see, we still have members missing. We will put the bill on call and lift it when they're here.
Thank you
Have
very
a great
much.
afternoon. I believe Assembly Member Williams, item number 2, AB 412, emergency medical services. And my understanding it's your birthday today, correct?
It sure is, Chairman. Thank you. You have
okay, well, I'm not going to
good intel there.
I'm not going to sing happy birthday to you, but happy birthday.
Thank you, Chairman. And members, AB 412 is a district bill which grants Santa Barbara County the authority to collect an additional $5 penalty assessment for driving under the influence and driving while intoxicated offenses. The revenue stream will fund emergency medical services in Santa Barbara County. The MADI Fund, established in 1987, authorized counties to create a fund to cover the cost of emergency care for the uninsured and other county emergency services. Currently, Santa Barbara is served by one hospital system and two smaller hospitals. The trauma center at Cottage Hospital is the only level 2 trauma center between Santa Barbara and the city of San Jose to the north and the city of Fresno to the east. You can imagine with this large geographic area, the increased strain on emergency services at this one location. The number of uninsured using the emergency room as a means of health care went from less than 10% in 1991 to over 30% today. Due to the increased strain on emergency rooms by uninsured patients, Santa Barbara County needs the authority to reestablish this fund.
and it received bipartisan support in the Assembly.
Thank you. Those in support, please state your name. Just let me remind you, there's no opposition. If we can just keep it short and brief. Thank you very much.
Dr. Takashi Wada. I am the Director and Health Officer for the Santa Barbara County Public Health Department. In strong support, I'm available for questions. Thank you.
Thank you. Next.
Mr. Chair and members, Monica Miller on behalf of the County Board of Supervisors for Santa Barbara County here if you have any questions, and we urge your support. Thank you.
Yes, next.
Mr. Chair and members, Tim Madden, representing the California chapter of the American College of Emergency Physicians. We're the sponsor of this legislation and available to answer any questions.
Thank you. Next.
Thank you, Mr. Chair, members of the committee. Carolyn Jenna with the California Medical Association in strong support.
Thank you. And I believe Senator Strickland had a comment.
I just want to thank the Assemblyman, say happy birthday, and also the very important issue in my district. We have overlap in Santa Barbara County. I'll support it. I want to thank you for carrying this important measure.
Thank you, Senator.
With that, I'd like to move the bill.
We have a motion to move the bill. Senator Strickland. It's due pass to public safety. Just real quick comment. I'm going to support the bill. It's a good cause. My concern is that I believe this is the third time that we've asked for extension. Maybe next time we may want to consider eliminating the extension or have that discussion. But any other questions from any of the members? Okay, seeing none, this is due pass to public safety. Secretary, call the roll.
Senator Hernandez.
Aye.
Hernandez, aye. Strickland.
Aye.
Strickland, aye. Alquist. Aye. Alquist, aye. Anderson. Anderson, aye. Blakesley. DeLeon. DeSaulnier. Rubio. Wolk. Wolk, aye.
That has 5. We will still put the bill on call to allow the absent members to add on. I believe you have one more item, item number 14, AB 1245, emergency medical services. Is that correct?
That's right, correct,
All right.
Mr. Chair.
Please proceed.
I would like to start off by thanking the committee staff for working with my office, and I'm happy to take the suggested amendments. AB 1245 enables the State Emergency Medical Services Authority to move forward with developing a specified emergency medical responder course, but prohibits EMRs from being added to another practitioner in the EMS system. This bill will ensure that if EMRs are inclined to be allowed to participate in the EMS system, they will need to come back to the legislature for guidance on how to best structure their scope of practice and certification process. The Emergency Medical Services Authority is currently in the process of developing the regulations for an EMR course. This bill does not interfere with that process and has minor and absorbable costs associated with it if the authority chooses to continue with the development of the regulations.
We have a motion to move the bill. Excuse me. We do have opposition, so those who are in support, please state your name and your position.
Mr. Chair, members of the committee, Christy Baumer representing the California Professional Firefighters. I would just add that this legislature spent more than 6 years, which is longer than the normal term of an assembly member in this House these days, working on a statewide system to ensure that their pre-hospital EMS personnel are subject to background checks, participate in a central registry so everyone has access to the condition of their certification or license, and is subject to consistent standards for discipline and quality improvement. So this bill just ensures that EMRs will adhere to those same standards by coming back to the legislature for such approvals. We're in support.
Thank you. Next. Is anyone else in support? And those in opposition? Any questions from any of the members? And we have a due pass as amended to appropriations. The chair will be recommending an aye vote. Seeing no further questions, Secretary, call the roll.
Senator Hernandez.
Aye.
Hernandez, aye. Strickland. Aye. Strickland, aye. Alquist. Aye. Alquist, aye. Anderson. Aye. Anderson, aye. Blakesley. DeLeon. DeSaulnier. Rubio. Wolk.
We have 4. We have members absent. We'll put that bill in call.
Thank you.
Thank you, Assembly Member.
Mr. Chair,
Yes,
I'm sorry for the delay. I have a letter of opposition from one of my counties, so I will stay off, and then when this gets to the floor, which I think it will, I'll know by then what's going on with him.
Thank you, Senator.
Thank you, Senator. I believe Assembly Member Monning, did I see him? Yes.
Good afternoon, Mr. Chair, members. Good evening.
Good afternoon.
I've followed with interest your very thorough hearing earlier on AB 52.
And I
I do
believe-
have two bills.
Okay.
Would AB 922?
Great. We'll do that one. That's Office of Patient Advocate, correct?
Yes. Thank you, Mr. Chair, members. The Federal Patient Protection and Affordable Care Act significantly expands health care coverage to uninsured people through public program expansions, a temporary high-risk pool, a mandate to purchase coverage, and by requiring guaranteed issue of coverage. AB 922 is designed to prepare for this transformation. As we prepare to expand coverage to over 4 million Californians, we need one place where health care consumers can access information about their health plans and providers and get help fixing problems they might encounter. Currently, California has a fragmented system of consumer assistance for health care coverage complaints. There are 8 governmental entities and a number of private nonprofit entities that provide assistance with public and private health care coverage. Approximately 3 million of the newly eligible population will qualify for Medi-Cal, and many of these people have had limited exposure to health care systems. AB 922 will streamline the confusing and burdensome number of offices and agencies that exist to assist consumers. This bill will help connect newly insured people with different language and cultural needs and integrate them into better understanding their care options. To ensure accountability to health consumers, AB 922 makes the Office of the Patient Advocate an independent agency and requires the collection of data and public reporting on consumer complaints. It is imperative that Californians have a single source of correct and current information about the ACA. This bill will ensure that people get clear and understandable consumer information and assistance by expanding and strengthening the current programs consistent with the federal requirements. I respectfully ask for your aye vote. We have some witnesses here in support, and Mr. Chair would appreciate the opportunity to present that testimony in support.
By all means, please proceed. Those in support, state your name.
Mr. Chair and members, Vanessa Kahina, glad to be here with the Western Center on Law and Poverty and glad to be a co-sponsor of AB 922. We believe that as we go into what is going to be a brave new world in 2014, enrolling just under 5 million people into health care coverage, that there needs to be a one-stop shop in order for people to get their questions answered, problems solved, and get referrals on very basic questions that don't always necessarily need to go to the next level. So what we're talking about is, do you have a PPO? Do you have an HMO? Are you in a DOI plan? Are you in a DMHC plan? Are you in Medi-Cal? Are you in Medi-Cal managed care? Are you in Medi-Cal fee-for-service? I can keep going. But the main issue here is that folks need one place to go. A lot of the people who are going to be getting into health coverage in 2014 are people who haven't been covered in the past year. A lot of these people have different needs than other people who are currently enrolled in coverage. So what we're looking at is having one centralized place, the one-stop shop. We also very much appreciate the fact that this bill allows the office to contract with community-based organizations which can provide those direct services to people who are maybe not part of the web savvy world or people who don't want to get questions answered over the telephone. We thank the author for his work on this bill and request your aye vote.
Thank you. Next.
Beth Capel on behalf of Health Access. We're pleased to be co-sponsoring this measure. We note that the insurers and health plans who oppose this measure argue that it's duplicative. On the contrary, for example, the Medi-Cal Managed Care Ombudsman has 6 people to serve 7 million enrollees. The ratio of one consumer assister to 1 million people seems to us a little inadequate. The Department of Managed Health Care provides, through its HMO Help Center, currently provides service to many. We need a place to go, whether you are on Medi-Cal or Medicare or the exchange, or you don't know what you've got, whether it's regulated by the Department of Labor or the Department of Managed Health Care, so that you can get the help figuring out which regulator regulates your product, which coverage program you're in, and maybe actually solve your problem before you have to file a formal grievance when you just pick up the phone and call. That's the goal of this, and that's why we're happy to co-sponsor.
Thank you. Next.
Mr. Chairman, members, Tim Shannon, representing the California Association of Marriage and Family Therapists. We concur with the testimony you've heard previously about the importance of this. It's particularly important when you're talking about patients with mental illnesses and their mental health coverage. Very important that they are able to talk to someone in a one-stop shop, as has been mentioned. We appreciate the authors taking amendments to address that very important issue. Thank you.
Thank you. Next.
Thank you, Mr. Chair. Allison Lobb, California Coverage and Health Initiatives, urging your aye vote, also on behalf of the 100% campaign.
Thank you. Next.
Stephanie Hodson with United Ways of California, and we're in support of this measure.